Good morning, everyone. My name is Dr. Mallouf. I'm a cardiologist in Beirut. I'll be discussing today the use of ticagrelor in patients with acute coronary syndrome, non-ST elevation, MI. These are my disclosures. So our case is a 75-year-old man who was transferred to us from the emergency department of another hospital with a diagnosis of non-ST elevation MI. 1 week prior to admission, he had an episode of new onset exertional angina. And the day of admission, he had a 10 minutes resting angina associated with diaphoresis. This episode occurred 12 hours before his admission to our institution. He's an ex-heavy smoker and known to be hypertensive for 10 years, controlled on CCB. His surgical history was unremarkable. His vital signs were stable. His physical exam was normal. And his blood test showed a slightly elevated troponin with a normal creatinine clearance and a normal hemoglobin. The bedside echocardiography was normal. His EKG was straightforward. He had PVCs and ST depression in the lateral leads with T-wave inversion. In the emergency department at the other hospital, he received clopidogrel 300 milligrams, aspirin 325 milligrams, and Lovenox 80 milligrams. So how would you manage this patient with the oral antiplatelet treatment? Would you continue with clopidogrel maintenance dose? Would you add a 300 milligram loading dose of clopidogrel and continue with that medication? Would you continue with ticagrelor maintenance dose? Or would you add a loading dose of tica and continue with the medication? Or would you just wait until catheterization and load with prasugrel? Well, the recommendations for oral antiplatelet agents, according to the new ESC guidelines, were not to use clopidogrel except in situations where you cannot receive ticagrelor or prasugrel. Prasugrel in this patient is not recommended considering his age, 75 years. And there are other problems with the prasugrel, like if someone is thin with a weight of less than 60 kilograms, or if they have a history of cerebrovascular accident. So ticagrelor is recommended for this patient, especially that he did not have any incident of intracerebral hemorrhage in the past. The loading dose of ticagrelor is mandatory in this patient, as outlined in this guideline. This comes from the Plato trial that showed that ticagrelor patients had much better outcome than the patients on clopidogrel as far as composite endpoint of cardiovascular death, MI, or stroke. The specifics about that, more interestingly enough, is the myocardial infarction and cardiovascular death. In these patients on ticagrelor, they did much better than those who were on clopidogrel, with the two curves improving after 2 months and continuing to diverge at 1 year. The incidence of stroke was similar in the two groups of patients. What is almost also interesting was the finding that definite stent thrombosis was much less in the ticagrelor group. So in our emergency room, he received ticagrelor 180 milligram loading dose, and he was started on maintenance dose of 90 milligram PO BID. So the question, obvious question, was how much would you give aspirin? Would you give it in a small dose, 100 milligrams or less, 100 to 200 milligrams, 200 to 300 milligrams, 300 to 500, or more than 500? Well, the answer to that is in the Plato geographic analysis, where they found that patients who receive high-dose aspirin did worse than patients who received low-dose aspirin, especially in the tica group. And from this Kaplan-Meier curve, you could see that the patients who were taking high-dose aspirin with the tica group, they did much worse than those who were receiving the low-dose aspirin. There was no significant difference in the clopidogrel group. There are many theories about that have to do with the probably smooth muscle cells, the vasodilatory effect of aspirin at low dose versus high dose. but there is no consensus about that, and more has to be done about these solutions. Now, the question that really comes about is, how would you manage this patient now? Would you treat him medically? Would you take him directly to the cath lab? Would you catheterize him in less than 24 hours? Or would you keep him for 3 days and then catheterize him? Well, you have to risk stratify this patient. And according to the GRACE risk model, his in-hospital probability of having complications is about 159, and this falls in the category of high-risk group. And the recommendations for that are really invasive strategy within 24 hours. The patient underwent a cardiac catheterization the next day, which showed severe stenosis of the distal circumflex artery. And it did show also an ulcerated lesion of the proximal LAD, making the acute coronary syndrome a systemic problem and not really a problem that has to do with only one vessel. So the patient underwent successful PCI and stent placement on the circumflex. And a few hours later, he developed severe chest pain, which turned out to be a large hematoma of the left pectoralis muscle. The vital signs were stable, the EKG was unchanged, and the hemoglobin slightly dropped by 1 point. Now, urgent decision need to be taken. Would you stop antiplatelets? Would you change the antiplatelet therapy? Would you transfuse the patients with platelets? Would you transfuse him with blood? Or would you wait and see? The definition of major bleedings do not apply to this patient. He didn't have any major bleed in any intracranial area or intrapericardial area, and the drop of hemoglobin was not that significant. So he falls in the category of minor bleeding, and these patients should preferably be managed without interruption of active treatment. Now, do you consider the initial risk of this patient in the bleeding score as very low, low, moderate, high, or very high? From the Crusade bleeding score, normogram, his risk score was 21, and this makes him as a low risk for major bleeding. Did ticagrelor increase the risk of bleeding in this patient? Maybe, yes or no. Well, what we know is from the Crusade trial that the rate of major bleedings, anytime you add any antithrombotic or anticoagulant, will increase irrespective of antithrombotic or anticoagulant. And the bleeding, when it happens, it kills, especially if it is life-threatening or major, but not if it is a minor bleeding. The Plato trial showed that there was no significant major bleeding outcome compared to clopidogrel. And this is probably due to the fact that fatal intracranial bleeding, although was significantly more in the ticagrelor group, the fatal GI bleeding was less common in that, and this is why they balance each other. Major bleeding events, according to the Plato criteria, was slightly more elevated in the PCI-related group in the TICA group, but there was no difference in the coronary angiography group. So what is our take-home message? Antiplatelet therapy plays a central and crucial role in the management of non-ST elevation acute coronary syndrome. And with increasing choice of these antiplatelets therapy that are more potent and more effective, the treatment protocols are becoming less standardized and more difficult to follow. Guidelines have been established to help us balance the risk-benefit ratio and to manage complications. And finally, what is the future? The future, we need to have more answers to many questions, and these answers has to be simple. Thank you.